Hello friends, this is a case of sleeve gastrectomy and here we are using a stapler, that is the robotic stapler, which will act as a grasper as well whenever we need, and we will use the stapling and the short gastric simultaneously. Alternatively, here a small retrogastric tunnel is made 6 centimeter from the pylorus, and in that we will introduce the stapler, that is a smart fire stapler from the Da Vinci. And once this tunnel is formed, after that, first we will fire a stapler, and then alternatively we will keep on taking the short gastric as well. So the advantage is that it will act as a grasper also whenever we want. And here the bougie is introduced, that is 36 French gastric calibration tube. And this is the first stapler which is fired, taking care of that you should be 6 centimeter away from the pylorus and 3 centimeter from the incisura angularis. So the advantage of the Da Vinci stapler is that it can act as a grasper also, and here it is ready to fire, and it will fire. Now firing has started, and on the left lower corner you can see one line is developing, and then it is unclamping. So it is a power stapler from Da Vinci, so it will automatically fire. And if you want, you can use it as a grasper also to lift the stomach whenever you want. So as long as the vision is good, you can fire the second cartridge, and the remaining cut part of the stomach we will separate from the short gastric later. So now this is again ready to fire. And on the left lower corner of the screen, you can see it is writing ready to fire. And once firing is started, one straight line will move and it is firing. And now it is unclamping. And this is the second cartridge which is fired. After that, we will lift the stomach again to make it sure that there is no any adhesion in the posterior wall of the stomach. And if the adhesion is there, you can use any ligature assistant can use, or you can use, if you want, you can use the robotic vessel sealer also. You can see there is a small oozing from this area. Then you can take a titanium clip and you can apply over that so that this oozing will stop. And now again, this is the third cartridge which is coming. And still the cut part of the stomach is attached with the short gastric, which we will separate later. So this is the third cartridge, and you should make it sure that anterior and posterior wall is equally pulled so that you cannot make a cork screw appearance. And we should try to remain as near as possible to the gastric calibration tube, so you can articulate the cartridge also. And now it is again ready to fire, and firing in 1 second, and this is the firing started. And now this is again unclamping. So this is the third cartridge also fired. After that, again you can lift the stomach with the same cartridge. With the stapler itself, you can use it as a traumatic grasper, because it has two mode. One is grasper mode, another is stapler mode. So right now it is acting as a grasper mode to lift it, and you will check the retrogastric tunnel. And if it is required at the level of the fundus, you can do some dissection with the ligature, and you can see that you are reaching up to the diaphragm, and the entire fundus is separated posteriorly. So we can see diaphragm is visible now. And now this is the fourth cartridge which is getting fired. So this is the fourth cartridge is loaded, and now it is coming, and again you will introduce into this tunnel and you will fire it. So minimum 5 cartridge is required and maximum 7 cartridge is required in the sleeve gastrectomy. We have to be also careful that you need to make a dog ear once you reach the last cartridge. So this is the fourth one firing, and firing has started. And now it is unclamping. After that, again we will lift the stomach to just to check that entire adhesion of the stomach in the posterior wall is clear. And then this is the loading of the last cartridge, that is the fifth one. So right now again it is in the grasper mode. So you can lift it and make it sure that it has all the posterior adhesion separated. So in this tunnel it will be introduced, and here we can see below is the spleen. And in the last cartridge you must be careful that it should be 1 centimeter away from the angle of its, that is gastroesophageal junction, and both the limb of the cartridge is visible. And now it is again ready to fire. And once you will see the both the, you can ask the assistant to lift the lever little bit. If the vision is uploaded, then the lever, and then it is firing. And we can see now stomach is entirely separated and it is no more attached with the remaining stomach. So now this cut part, you can ask your assistant, or if you want to use the vessel sealer of the Vinci, then that also you can use it. And slowly it is separating. During this separation, we have to be careful that excessive traction should be avoided. Otherwise, you will avulge the vessel and bleeding will start. So, both the way robotic sleeve gastrectomy can be performed. One way is that you take all the short gastric first and then you use the stapler. And other way is that you make a retrogastric tunnel and fire the stapler and then you separate the short gastrics. So here we have taken the second method, and this is slowly you have to remain as near as possible to the stomach. And here this is a laparoscopic ligature. We are not using the robotic vessel sealer or robotic harmonic. The Da Vinci has you can use the harmonic also. And Ethicon is making the harmonic probe to use in the same generator, which you can use if you want robotic. So basically you can say it is not a total robotic sleeve gastrectomy. It is a robotic assisted sleeve gastrectomy, you can say, because this part we are using by the laparoscopic ligature. However, robot is assisting. The left hand atraumatic grasper is the robotic grasper. And on the right side, you have a laparoscopic grasper and laparoscopic ligature. This patient has no adhesion with the spleen, no adhesion with the stomach, and there was no adhesion with the posterior wall of the stomach. However, in the patient, if it is alcoholic or a smoker, severe smoker, then you will get a lot of adhesion in the posterior wall of the stomach. And in those cases, it is always better to take the short gastric first. So you can fold the stomach and you can do a adhesiolysis of the posterior wall. So assistant is retracting all the momentum towards the left, and robotic grasper is pulling it anteromedial remaining stomach so that you will have a proper plane, and with the ligature it can be separated. Sleeve gastrectomy is a very simple straightforward surgery. Either you do it by the robotic or you do by a laparoscopic. It is not a difficult procedure and you can easily perform with both the methods. So just a few more centimeter of the separation is required, and in this area you should not pull the stomach very forcefully, cordially, because you may expect some adhesion with the spleen. So you have to be gentle and it should be separated. But in this patient there was no any adhesion, so it's a very easy case. Here we have used the table attached Nathanson liver retractor, which is retracting the left lobe of the liver. Below is the spleen, as you can see, which is visible, and now just few more centimeter is remaining. Assistant is lifting the left lobe of the liver a little bit, so the vision will be good. And now surgery is over. After that, you can undock the right side of the port. Robotic cannula can be removed and directly percutaneously. This is the right side, that is left instrument is on the right side. So this will be removed first after pulling the stomach little bit. This left atraumatic robotic grasper will be removed, and then you will catch the pylorus and distend the stomach with the 50 cc of the methylene blue diluted saline to see the bulge, and you can see clear cut this bulge is visible, and then you can check the any leak. So there is absolutely no leak, so it is very easy to check the leak that way. If you want, you can do endoscopy also, and after that this atraumatic grasper will be removed. Bougie also will be taken out, gastric calibration tube should be taken out, and then you will pull the stomach. So you can see there is no leak throughout the staple line, and after that this is pulling the cut stomach, and then this grasper is undocked. This cannula of the right hypochondrium also will be removed, robotic cannula. This is robotic cannula which is taken out, and there is a sponge holding forceps which is introduced through that. And this stomach, you have to stretch little bit rectus, and this port must be closed because to prevent hernia. And then up, down, right, left you will do, this stomach will come out. And after that, you can remove the Nathanson liver retractor. So thank you very much for watching this video. This was a simple case of robotic assisted sleeve gastrectomy, which was performed by the laparoscopy as well as robotic assisted.